Dear students, welcome to this recorded lecture on the subject immune deficiency. I'm Professor Reda, Professor of Pediatrics, Faculty of Medicine at Chance University. You are expected to watch this lecture before attending the face-to-face session. This lecture consists of 4 parts and will provide you with the basic knowledge of immune deficiency, which will help you to better engage during the face-to-face session. By the end of this lecture, you should be able to recognize first definitions of primary immune deficiency and secondary immune deficiency, when to suspect primary immune deficiency diseases, the PID diseases, and to understand the basic categories of primary immune deficiency diseases, the clinical features of common PID diseases, the basic laboratory tests required to diagnose PID diseases in suspected patients, and secondary immune deficiency causes in terms of causes, and lastly, the management of HIV infection in children. First of all, let me remind you of the cells of the immune system. The circle on the left side includes cells of innate immunity, the macrophages, neutrophils, natural killer cells, eosinophils, basophils, and dendritic cells. These cells have a rapid, non-specific response, which means they deal with all kinds of pathogens, whether viruses, bacteria, fungi, or parasites, on first exposure. The circle on the right side includes cells of the adaptive immunity, the lymphocytes, mainly B cells and T cells. The B cells are responsible for the humoral immunity by producing antibodies, while the T lymphocytes, the T helper cells, and T cytotoxic are responsible for cell-mediated immunity. In the area of overlap between the two circles, you can see T cells and natural killer cells. These two cells have important function in both innate and adaptive immunity. So by definition, primary immune deficiency diseases are a group of rare genetic disorders that affect the development and function of the innate and/or the adaptive immunity. So these disorders are inherited. Most patients have increased susceptibility to infection by common as well as uncommon organisms. On the other hand, secondary immune deficiencies, which are more common, here the individual is born with normal immunity, but a secondary insult or a secondary factor, which is acquired, affects the number and/or function of the immune cells. The incidence of primary immune deficiency ranges from 1 to 300 to 1 to 20,000 live births. The mode of inheritance is either autosomal recessive, autosomal dominant, or X-linked diseases. And because we have many X-linked diseases in primary immune deficiency, boys are affected more than girls, with a ratio of 5 to 1. The age at onset of symptoms varies. Severe forms usually start during the first year of life, while mild form may show up later. The question here is when to suspect primary immune deficiency. First, there is principles of infection in primary immune deficiency that characterize these infections from other common infections that occur in non-PID patients. The infection is recurrent, persistent, or sometimes severe infection with fulminant course. The infections are usually caused by low virulent organisms, what we call opportunistic organisms. Infections involving multiple organs, like you get pneumonia, you get encephalitis, you get liver abscesses, for example, gastroenteritis, skin infection, all in one patient, or sometimes you get multiple sites of infection within the same organ, like you get multiple liver abscesses or multiple abscesses in the lungs. The warning signs, here we have the expert committee of primary immune deficiency postulated these warning signs just to alert the physicians and families of the possibility of immune deficiency whenever they find one or more of these warning signs. First, we have 4 or more new ear infections within 1 year. Second, 2 or more serious sinus infections or an episode of pneumonia within 1 year. Third, we get 2 or more months on antibiotic with little effect, little improvement. The fourth warning sign is failure of an infant to gain weight or grow normally. So we have failure to thrive. The fifth, recurrent deep skin abscesses or organ abscesses or septicemia. Then we have persistent superficial candidiasis, oral candidal infection after the age of 1 year, or you get episodes of opportunistic infections, or sometimes you have complications associated with live vaccines, which I'm going to mention later, the need for intravenous antibiotics to clear infection. This is very important. It indicates that the infection was severe, indicating admission to hospital. The 10th warning sign is 2 or more invasive infections per year. You get encephalitis, meningitis, or you get hepatitis. So you have these invasive infections. And then if you have a family history of primary immune deficiency, 1 or more of the family members have immune deficiency, or previous sibling death of infection. The last is the unexplained autoimmune diseases, like you get autoimmune hemolytic anemia or autoimmune thrombocytopenia early in life. So what are the main categories of primary immune deficiency? Currently, the WHO, the World Health Organization, lists over than 150 primary immune deficiency diseases, and the number is growing month after month. Of course, we are not going to demonstrate all these diseases, but these diseases are actually grouped into 9 main groups of primary immune deficiency. Here in this lecture, I'm going to focus on the 4 main groups of primary immune deficiency that mainly present with infection. The first group is combined T and B cell immune deficiency. The second is predominantly antibody deficiency. The third group, phagocytic innate and complement defects. And the fourth group, combined immune deficiency with syndromic features. And here I'll begin with the combined T and B cell disorders. The best example here is the severe combined immune deficiency, in which infants, if not diagnosed early, they die before achieving their first birthday. The characteristics of this group is the onset of symptoms is before the age of 6 months. The onset is very early in the infant period. There is various opportunistic infections with viruses, bacteria, fungi, and parasites. There is oral thrush, excessive diarrhea, and failure to thrive. In addition, these infants usually suffer from complications of live vaccines. These vaccines, the BCG, the oral polio vaccine, the rotavirus vaccine, the measles, mumps, rubella, MMR, are usually administered within the first 2 years of life. The last thing is that these patients are liable to develop lymphopenia. The lymphopenia here, this is a characteristic feature. The absolute lymphocyte count is usually less than 3,000 per cubic milliliter at birth, or 2,800 per cubic milliliter during infancy. Complications of BCG in SCID are very common. Here we have, if you can see the photo on the left side, this is a lymphadenitis. The axillary lymph node is swollen and inflamed. It is after the administration of BCG. The BCG, the universal site for the administration, is on the upper lateral quadrant of the left arm. So here, as you can see, this is the site of inoculation of the BCG on the right photo, while on the left photo you can see the draining lymph node, the axillary lymph node is inflamed with the BCG itself. This is what we call local BCGitis. It can have another stormy effect, the BCG, on patients with severe combined immune deficiency. Here we get the disseminated BCG infection. The dissemination occurs in the lungs. As you can see with the black arrows here, you can see the opacities all over the chest. It occurs in the skin as well. You get the red papules on the skin. And here, the photo number 3, you can get here the ulcer at the site of inoculation of the BCG vaccine. These patients usually die due to the disseminated BCG infection, and they have the worst prognosis. Of course, dissemination can occur in the liver, in the bone, in other sites, so this is a very serious side effect or complication of BCG infection. And we'll meet in part 2.